Well, I think we have to be very careful about saying we replace a treatment that's been in place for the last 20 to 30 years and clearly shown efficacy with a consistent progression-free survival advantage. And certainly in the early days, autologous transplant provided clear overall survival advantage. I think what we've come to recognize, though, is that in 2021, the therapeutic horizon is so much dramatically bigger, and immunotherapy has literally revolutionized the field. So my position was clearly Melphalan matters. It targets stemness, it brings tumor burden down, and autologous reconstitution resets autologous immunity in the younger transplant-eligible patient. The trouble is there are downsides, and they're pretty important. They include, most importantly from a patient perspective, acute toxicities and impact on quality of life, but biologically as well, we clearly see a strong signal for secondary cancers, and in particular myelodysplasia and AML in the long term. Fortunately, these risks are small, but the actual risk doesn't plateau. There's a constant linear gradual increase over time. So as our patients live 15, 20 years now, whereas a leukemia risk 10 years and 15 years ago was very small, now we're seeing patients living longer. This has to be a factor we have to bear in mind. That being said, it is clear that Melphalan makes a big difference, and it drives a progression-free survival advantage that is tremendously important in the transplant-eligible patient, and it's enhanced by maintenance, particularly maintenance until progression. That makes a big difference. But can we do better? Can we improve on the status quo? And our suggestion would be that you can, because one size clearly does not fit all. There are patients who do benefit from effective cytoreduction from first triplet regimens and second now quadruplets. They achieve an MRD negative state, and you may not need to use your high-dose Melphalan with autologous support in those patients. You may get to where you need to be and maintain that remission for a very prolonged period. And the use of MRD as a tool, certainly in the research setting, to guide us, makes a lot of sense. So my position was really, Melphalan matters, but how can we do better? And so the construct was, what do we have in the toolbox looking to the future that's going to transform outcome? And there it was very exciting, because we were able to present the really exciting plethora of options we have, both in terms of antibodies, CAR T therapy, so cellular therapy that could augment what we already do in the early stages of disease, and above all also the potential of bispecifics, where these truly more off-the-shelf approaches could be deployed in younger patients. Now, a lot of work to do, and in a relatively evidence-free zone right now, but nonetheless the basic building blocks are there that you can actually do. You can keep transplant in reserve in patients. It doesn't impact on overall survival, but it does allow you to improve PFS in those patients who most need it. And so my thought point here was really looking to the future and saying, what's the future hold for younger patients? And can we get to even more durable disease control with effective immune strategies, cytoreduce patients, whatever that may look like, but do so with less toxicity and better quality of life?